Thank you so much for joining in. Today's program is organized by Planetary Health Academia. I have a special thank to Nusrat Nafisa for making the poster and running the program. It is sponsored by Incepta and United Hospital. And we have a speaker, Dr. Muhammad Nazmul, MD, MRCP. He's my colleague, but he's in a different town. He's a clinical nephrologist, works for CHI Nebraska, but he's also assistant clinical professor at Creighton University School of Medicine in Omaha. Dr. Nazmul is an academician in his own way. In terms of teaching, he also has several publications in leading journals. Now I'd like to introduce our distinguished panelists. We all know Professor Muhammad Rafiqul Alam. Sir Manahai, I think he's going to join in, inshallah, pretty soon. We all know that he's former Pro Vice Chancellor and former President of Bangladesh Signal Association. Next, we have Professor Muhibur Rahman, FCPS, MRCP, and PhD, former head of Department of Nephrology at Sir Salimullah Medical College and Mitford Hospital. He's currently a professor at Popular Medical School. Then we have Professor Qazi Alam Shahanur, FCPS MD, and he's the head of nephrology at National Institute of Kidney Disease and Urology. We have great pleasure of introducing our own Professor Nurul Huda, MCPS MD, FCPS, and he's head of the department of this very dynamic leadership at Chittagong Medical College Hospital. Very thankful to Brigadier General Jainul Islam Bhai, MBBS, DCP, MCPS, FCPS, Histopathology, Fellow in Renal Pathology, AIMS, New Delhi. We are very excited to have him, and special thanks to him because actually he's traveling. He's currently in USA. I know jet lag and others, but thank you so much. And he's an advisor specialist in pathology at
online conference.
So again, thanks everyone. A special note for our young and trainee physicians. First of all, I'm very happy that two of our MD trainee physicians, Dr. Tahmidur Rahman, MRCP, and also Asma, both of them are going to present a case at the end of the session. Each of them will present one case. Also, I think there is a good opportunity to earn a present that is a Bluetooth phone device. But at the end of the session, you have to stick around. Dr. Nazmul is going to give you a quiz. Whoever answers that the fastest, he's going to get the prize. And Nusrat Nafisa is going to keep a tab. And we'll then ask you to give you your address that we can mail it to you. A final note is, see, medicine is going towards precision medicine, like we use targeted therapy and immunotherapy for cancer. So they are also depend on many of the genetic markers. So today's discussion will involve those things. It may seem theoretical, but our job as a physician is to be up to date in knowledge, whether we have the financial, like on the patient side, if they have financial or physical ability to do those, we still have to know what is the current trend. And that's why, please, especially for our junior colleagues and students, that please be patient. And should there be any questions, Dr. Nazmul will be happy to answer all of this, and also our distinguished panelists. With further ado, I'll leave the phone to Dr. Nazmul. Please go ahead.
Assalamualaikum, Imtiaz bhai. Thanks for your kind introduction. I'm very fortunate that আমি সবার সাথে আজকে এখানে we'll share our some knowledge and communication with each other about FSGS, which is one of the most common GN. And as all you can realize that যখন আমরা GN সম্বন্ধে কথা বলি, then the name basically is driven by kidney biopsy. So it's a biopsy proven diagnosis. So we are fortunate that we have a histopathologist with us, and obviously to be honest, I think the young generation will be more curious to learn about the future, the genetics, the precision medicine, the AI, machine learning. So inshallah, we'll touch base on that. So learning objectives, we'll look into current guidelines in management of FSGS, diagnostic workup in genetics. So we'll make it as kind of relevant clinical, for the genetic side too. So it will be more interesting and patient oriented. And future direction, we'll also talk about few things towards the end of the slide. And all you may agree that FSG is a unique kind of GN because this disease is also connected to the most common risk factors of CKD or even ESRD, like hypertension and diabetes. So I think in my mind, FSG has a special position when I see a patient, when I talk about nephrotic syndrome. So FSGS is a morphologic pattern of glomerular injury that is, visceral epithelial cell podocyte. That is one of the important part of the basement membrane. And just to give you an idea, podocyte is a N type of cell, like a neuron, because podocyte cannot regenerate, cannot proliferate. It can just, it can try to repair itself. And that's kind of start the mechanism of that inflammation and fibrosis. So, and then defines of presence of sclerosis in the segmental part in light microscopy. So as I said, microscopy is a very important finding, LM. And the IF is not that much important, but sometimes we can look at that if you have other suspicions of secondary disorders. And obviously EM microscope is important, but we can diagnose with our resources with the LM and clinical features. It's the most common primary glomerular disorder that high-grade proteinuria, and as was mentioning in ESRD in US, and the pattern of histological injury is rather than a disease. Like if you look at MPGN or, it's a pattern of disease and can be the primary and secondary to various underlying process. And it sometimes can be difficult. There can be overlap, there can be two diseases going on. So it is not always easy. But this is kind of a thing we have to keep in mind that kidney biopsy is the gold standard, even in certain case of secondary FSGS. Prevalence, I was saying earlier, talking about this prevalence, we have very high prevalence. About nephrotic syndrome in children is 20%, more in adult, 40%. These are in US population statistics. And 7 per 1 million. And it is the most common primary glomerular disorder in US with prevalence of 4%. I was looking at an article, like it was published in Bangladesh perspective. I think in Mymensingh Medical Journal, and they did a biopsy of, I think, more than 300 patients, and they've seen that the prevalence of FSGS is also top, 18%. I think it is similar to messenger proliferative. So in Bangladesh, I think FSGS is also one of the most common cause of nephrotic syndrome. And we can talk later with our আমাদের আছেন দেখেন তারা আমাদেরকে অবশ্যই এই ব্যাপারে information দিতে পারবেন ইনশাআল্লাহ. And nephrotic range proteinuria with or without other features of nephrotic syndrome is a classic presentation of primary FSGS and is seen in 70 to 90% of children and 50 to 60% of adult. So sometimes, obviously, nobody will deny that diagnosis start bedside. So clinical examination is very important. Children is obviously is easier than adult to diagnose from clinically, but both children and adults, this disease is very prevalent. Another unique feature of this disease. Now, I have a couple of slides that I want to share with you. Just so short, move it out down here. So one patient, a 32-year-old male, present with leg edema for several months. The duration is several months and no known medical problem. Young guy, non-smoker, no alcohol. GFR is pretty decent, 75 eGFR. Albumin is 3.2. So less than 3.5, the cutoff for nephrotic syndrome. And blood test, urine collection, obviously nephrotic, 5 gram, 24 hours. Kidney biopsy, as we expected, focal segmental glomerulosclerosis. EM reported patchy food process effacement. In future slide, we'll put as a FPE, food process effacement. So in addition to supportive care, I mean, medical management, what else shall we do the next best step? So next best step, I mean, maybe all of these are okay, but what will be the next step to pursue? আমরা কি genetic testing করবো? Or shall we just go straight ahead for immunosuppressive with the pulse dose steroid? Or shall we start a CNI? Or we'll just march to 3 months with medical management, with supportive care, with a RAS blockade? The second case is a little bit different. This is a male guy, black guy, and he also had EFGS, FSGS that has been treated for a year now, and he has his biopsy also shows FPE, and he also has secondary risk factors. I was talking about that earlier: hypertension, and 5 years well controlled with good medication, with a dual antihypertensive RAS blockade and calcium channel blocker. And his family history is also need to notice that his mother has CKD stage 4, and lab work again. His GFR is obviously worse stage. He's in stage 3B, GFR of 35, and albumin 3.2, protein creatinine ratio 4.8. In this patient, chronic kidney disease, which of the following best step we will do? Genetic testing, start immunosuppressive remission, or none of the above? And obviously, this patient is being treated with the RAS blockade. We know that. So, a case we'll keep in our mind, and when we towards the end we can discuss. And obviously, I'm very happy that the fellows have cases to discuss. We'll focus on those cases mainly. But this kind of case kind of give me some introduction to what we're going to talk about next. This slide কি froze হয়ে গেল মনে হচ্ছে। Okay, so what is FSGS? As I mentioned before, biopsy is the gold standard. So histopathological pattern of disease seen in light microscopy, not a specific disease, and podocyte injury, podocytopathy. That's kind of a buzz term, but this is very important to realize. Remember, proteinuria, nephrotic syndrome, decline in GFR, those are clinical presentation on the left side of the slide. And you have segmental sclerosis that you see in light microscope. On the right side, if you can look at that, and basically, if you look at the food process, effacement, so if you look at this is basically the basement membrane of the food process, and the podocyte, there's effacement of the food process on this area. I hope you can see my arrow. So that's what the EM biopsy will show. This is a little bit flare-up image. So, these are real patients. So if you look at the light microscope, first one, you see the dark arrow. So typical FSGS picture, segmental sclerosis, cellular hypertrophy, and obviously mesangial cell is more than 5 in that slide on that area. And if you look on the right side, there's a little bit of introduction. So both the A and B, both of these patients have focal segmental glomerulosclerosis. And then I kind of go back to EM with the light microscopy because it's kind of diagnostic, and also is good to look at the picture because the food process is better seen in the EM, obviously. I mean, so you see the food process again, effacement on this light arrow on the right side, first one. And then if you go with the second one, patient, again, similarly, it's a more silver stain of the light microscope. And obviously, this is FSGS picture, no doubt about that. And look at the rest of the glomeruli, they're pretty intact. I mean, you can see all the other structure pretty good, but this area is FSGS. And if you look at the kidney biopsy on that patient, again, you see that food process effacement. This is more like a patchy because you do see some food process here, podocyte food process, but compared to this one, this is more partial. So these are the kind of slides we are going to talk, going to our next subject. Now, how does this pathophysiology happen? As I said, first, it happened with the podocyte injury. So this is your podocyte. This is endothelial cell, blood vessel, and this is a podocyte. And if you see the podocyte this whole podocyte, the membrane, and you see the food process, and then it got detached. So podocyte is got detached from the basement membrane, and this detachment leads to inflammation and injury, and sometimes it can also start leaking of other inflammatory markers, and that kind of start the sclerosis with complete effacement of the podocyte. So this part, the last one, you see the whole podocyte is basically there's no more is sclerosed all the way. So the same thing we see in light microscope. The early changes may not be that much visible when the podocyte injuries start to happening, but যখন আস্তে আস্তে it become more diffuse damage, we see these light microscope changes. And when there is severe damage, obviously this sclerosis, and we can appreciate that better in light microscope. So this light and EM is kind of follow each other. This is something a little different. I just want to bring that. We'll talk more about in future, down the road if time permits. Glomerular scarring or glomerulosclerosis. So it's a different kind of pic. If you see the whole glomerula is basically lost its architectural pattern. This one in specific, okay. There is no anatomical variation. I mean, you don't see any kind of blood vessel that we see the glomerula in the previous picture. And there's obvious fibrosis, like a capsular fibrosis in the parietal and visceral epithelium, like almost like onion skin appearance. So this is not FSGS. This is obviously glomerulosclerosis. This is, we call it glomerular scarring. And if you look at the other glomeruli, that may be intact, but this one is obviously glomerular sclerosis scarring. And you also look at the interstitium, look at sometimes their secondary changes can happen. There can be neutrophil, maybe something like inflammation happened before vasculitis, or it can also happen with hypertension, obesity, and aging. So the pathologists, they always look on the slide and they know this is not the FSGS, this is more scarring picture. Okay, so this cartoon will give us a little bit of more, like understanding how that mechanism works, as we just talked about. And you see the podocyte cell here. I was talking about the body, the nucleus, and the food process. These are normal glomeruli. This is the efferent and efferent arteriole. So this is your hilum, and this is the parietal, basically the parietal epithelium. This outer layer, and the visceral layer is basically podocyte is the part of the visceral epithelium covering the mesangium as well as the arteries, the glomerulus. These are the glomerulus, nuclei. And then this two part is important. If you look at, there is a junctional area between the podocytes on the basement membrane on the visceral side, and there's also a podocyte that is directly connected. And this part where these are the parts where inflammation happen, and the genetic mechanism also involve this transport mechanism. We'll talk about that also, like those TRP6. Transported protein, calcium transportation protein 6, podocyte nephrin, the slit diaphragm. We know all about these things. They are the place where the injuries start happening and where the proteins start leaking. And in the podocyte itself, there's other protein material present, like laminin and actinin, and this kind of part of the podocyte cytology. And these also play a role in genetic FSGS, but less common than these are the ones like your TRP6 or podocyte nephrin. These we all know, even with nephrotic syndrome. It's important to realize this genetics. Next slide. So let's go to some classification. It's always good to have some understanding, especially for the fellows and residents, Jay. We try to put like a format to put it in the diaphragm in the table, so we can really make it easy to how to diagnose. So first of all, primary, and then the secondary. So two big classification. Primary, specific cause unknown, and permeated by circulating permeability factors. So here, these are some like a protein material. One of them is like is called super. The soluble urokinase enzyme is in the plasma, and we'll talk more about that. And in a few cases, if you do transplant patient, the super can be high. There we can think about plasmapheresis, but usually that's not the treatment. But these circulatory permeability factors are talking about those. The other ones are like interleukin 30, IL-30, interleukin 50 family, like there is one called cardio podosin. So these are the ones they're calling some postulated mechanism of permeability factors. The secondary form, we'll talk about the genetic factors, but again, the other ones are also very important. Virus like HIV, parvovirus. Sometimes this disease, this virus history is sometimes hard to get from the patient, Epstein virus, cytomegalovirus. So I want to again emphasize history is always important. I'm not just saying that through the biopsy way diagnose of it. No, history is always primary way to diagnose disease. Drugs, always iatrogenic, drug induced. Some of them like lithium, pamidornate, even the CNI, the calcium inhibitors, they can do CNI toxicity. And if you look at that, among those immunosuppressive medication, CNI is more toxic to cause nephrotic syndrome compared to MMF or cytoxan. Anabolic steroid, another one. Now, the last category is a big category, adaptive. That is a secondary, majority of this because of this secondary cause of FSGS because of adaptive. So we can go through this different time, but blood pressure, hypertension, TMA, obesity, all these can lead to that. And obviously, sugar is also an important factor, but diabetes is obviously a separate category. So, but sometimes metabolic syndrome can also part of that adaptive FSGS, reflux, nephropathy, previous history, pregnancy, all this can cause secondary FSGS changes in adaptive variety. So again, as I was saying, now if you look at pathophysiological approach, it's kind of correlate with the initial, the other slide. So idiopathic or primary, familial, secondary adaptive, and focal on segmental glomerular scarring. So obviously this is not our subject today, but we're going to focus on these first three. Okay. Now, as I was stating, it is not always easy to differentiate from FSGS from focal glomerulosclerosis, but you have to look at the whole slide, and aging process, hypertension all plays a role in older patients. But what can be difficult sometimes that people can have FSGS and superimposed on your senescence change in the glomeruli. So you have to be careful that you have to look at all the as many glomeruli you can do, and especially look at the good glomeruli to see if they have any FSGS, because the bad one may be scarred already. So always look at the good glomeruli to diagnose. In contrast to FSGS, where the glomeruli is only part of that, like segment is involved. In glomerulosclerosis, like in scarring, the entire glomeruli is involved, is affected. And also look at the interstitial fibrosis and vascular sclerosis, which should be present in case of, which can be present, like if people have uncontrolled hypertension and they have this scarring from that. And glomerulomegaly patient is seen usually in secondary FSGS, adaptive, which is absent in case of age-related decline. As we know, with aging, we can have rather kidney atrophy. So these few things always keep in mind, that glomerulomegaly is usually FSGS, and renal atrophy is more common in scarring and glomerulosclerosis. And again, in case of glomerulosclerosis, there is no minimal or no food effacement in the unaffected glomeruli. So it is always good to look at the normal glomeruli, either in FSGS or in case of global glomerulosclerosis like scarring. This is kind of a big slide. I just want to bring it up. You can look at that if you want. I can share the slide. We can see that there's different things that adaptive, secondary FSGS. We talked about already, but these are kind of a thing that we look into the drugs, toxin, and stress on the glomeruli, viruses, and different other causes. The lower part is genetic cause. I apologize for the small font, but I'll talk more about that. But you can see there is a lot of different kind of mutation and Mendelian mutation and single gene mutation. But again, don't worry, we'll talk. Our sliders will be better, more focused on that. It's just to give an idea. The secondary and genetic is two different etiology now. Primary and secondary and genetic is separate. Now, so as I was talking about the overlap, it's always important because we have to think about the patient. Everybody's different. Everybody is, there can be overlap. There can be 2 or 3 diseases going on. But we have to look at the picture of the how the FSG is happening. The FSGS primary in the middle, obesity, unilateral kidney, genetic mutation, and steroid. The again genetic type maybe steroid resistance. They can sometimes overlap each other. This is a complex interaction of different causes. So we have to remember that. And also, I think a couple of fellows case we'll see that also they can be overlap. When treatment also can be guided by our decision making. With that, what kind of FSGS they're having, is there any connection between primary and genetic on that? Next slide. Again, we classify the FSGS, and we look at that primary, alteration of glomerular epithelial cell. So here you kind of see that there is a overlap of the mechanism for both primary and secondary. In both primary and secondary cause, because of virus and drugs and genetics, they've altered the epithelial cell, the glomerular epithelial cell, the one we're talking about, the parietal epithelial, the podocyte on those cells. So both those type, both the primary and genetic variants can affect that, and some of the secondary causes. In case of secondary cause due to reflux, dysplasia, obesity, those things, sickle cell disease, another thing, maybe more common in Bangladesh, they are caused because of the reduced nephron mass. So obviously, when the mass is less, the remaining mass or nephron try to do enlargement anatomically because they cannot proliferate. These are end cell, so they become larger and bigger in size. In reflux, nephropathy, renal dysplasia, obesity, glomerulomegaly because of that secondary changes. Just something to keep in mind. If you see, glomerulomegaly, you're thinking of secondary most likely because of obesity, or other diseases like renal dysplasia, unilateral kidneys. So something to keep in mind of this. Then next slide. Just wait. Wait for that. Sorry, I'm going to put it here. Taking time to change the slide.
If the slides are frozen, you can stop, get out, and join in again, and then move.
Yeah, I think let me pause sharing for a moment.
Yeah. Meanwhile, we'll digest what you just said. It's like very loaded. Okay. No worries. Take your time.
Yeah.
Apologies, everyone.
I think it's better you stop sharing. Okay. You can.
Yeah, I'm back now. Sorry.
All right.
Can you guys see now?
Yes.
Okay. So next slide. Again, primary and secondary, just to give you some idea difference between those two. Primary nephrotic syndrome, secondary variable degree of proteinuria. Occasionally, nephrotic syndrome can happen secondary if it's drugs and virus, because the mechanism is still going back into podocytopathy that I showed you in the other slide. Diffuse FPE in case of primary FSGS. And in case of secondary FSGS, it is segmental FPE, is not diffuse. And primary may respond to immunosuppression. And in secondary, as you all may agree, as a general, there is no role for immunosuppression. It's still happening again. Sorry, I'm just going to make sure why it's going like this. Okay. Now these are the things, the FSGS of undetermined cause, and despite different testing, including genetic testing, there can be patients that we cannot identify the exact cause of FSGS. Such patients are considered as unknown cause, and then are similar to the patient with secondary FSGS, the biopsy finding. And one study in USA has found that almost 60% of patients with the features of secondary FSGS remain unknown. So, I think,
Maybe you can get out of the slideshow. Okay.
I think I have to, I think you have to keep the mouse not moving a lot. So idiopathic FSGS, nephrotic syndrome, we talked about that, very common in idiopathic. Familial FSGS, these are kind of a clinical pearl. Familial FSGS, family history is very important, as we know, genetic disorder. Secondary or adaptive FSGS, adaptive is another name we kind of use sometime. You always think about previous history. Previously, if patient has glomerular disorder, they may have other vasculitis or pregnancy-related changes, and that can cause secondary adaptive changes, tubular interstitial disease, reflux nephropathy, thrombotic microangiopathy, and then we talked about the healed glomerulitis with the history of hematuria. Those are more sparing. Okay, and then focal and segmental. It can be focal and global also, but usually we talk about FSGS, focal segmental glomerulosclerosis. It have, as I said, metabolic syndrome, vascular disease, they cause FSGS, structural and functional adaptation, glomerular hypertrophy, we talked about that. Glomerular visceral epithelium may be preserved. And this is something, keep in mind that isolated glomeruli with foam cell can sometimes show in the microscope, in the light microscopy, which are diagnostic of hyperlipidemia type 4, in patient with the right setting, obesity and metabolic syndrome. Something that might give you some clue. Primary and secondary FSGS, try to just to visualize these differences. Sudden onset, primary history is important. Secondary, slowly progressive. Nephrotic syndrome in primary, non-nephrotic. But again, these are general, but there can be overlap. No history of any prior disease, and history of prior disease in secondary, pregnancy, vascular disease, we talked about that. Glomerular is normal size, and in case of secondary, there can be glomerulomegaly, nephronomegaly, hypertrophy, diffuse effacement, we talked about that. And in case of secondary, food process largely preserved, and no significant parenchymal atrophy in primary, and pre-existing kidney injury. So kind of connected with what we all started that difference. Now, this is a picture of secondary FSGS, general FSGS that we have kind of classified by the pathological findings. The top one is not otherwise specified FSGS in OA. That is the most common type. If you look at that FSGS type, it is the food process can be effacement, can be variable. And these are the things that they are more common in genetic form, this kind of not otherwise specified and secondary type of FSGS. And they can cause both subnephrotic and nephrotic range proteinuria. The first one, top, is not otherwise specified. The next one is perihilar. If you look at that, the FSGS pictures in mostly in the hilar space, as we talked before, the efferent artery of the hilar spaces there, and they're also common in adaptive type. Food process effacement also can be mild, but it can vary, and this is also common in people with obesity. That you have this hilar variant of FSGS and other cause like sickle cell disease, reflux nephropathy. We see more of this kind of FSGS secondary hilar variant, perihilar. Cellular is basically the endocapillary perifiltration. This is more common in primary type of FSGS. that idiopathic FSGS, you see more of this kind of finding in your light microscopy. And but again, even in primary one, you can sometimes see other findings like people can have foam cells if they have hyperlipidemia, metabolic syndrome. But these are if you have this kind of morphological variation, is cellular, maybe it's most likely primary. Tip variant, again, these are this tip variant FSG is sometimes difficult to discern or separation from minimal change disease, because tip is just on the one corner, as you see on the tip, and it can be missed, sometime on our microscope examination. But tip variant is obviously has the best prognosis, and usually this is primary, they respond to steroid, and it's again, it can happen because of stress from leaking protein. And this usually has the least amount of interstitial tubular changes, tubular atrophy. So that's why, as you know, the tip variant is better prognosis, as I was saying. Coming to other one, the collapse type, I think we all know about that. Collapse type, HIV kind of goes synonymously. If you look at the picture, is the whole the anatomy is distorted. It's kind of shrinked glomeruli, and it can be happen both primary or secondary. And whenever it happens in secondary, you think about HIVAN in HIV in right setting. The other viruses can also cause even like infection, like even tuberculosis, other diseases can cause this kind of picture. So if you look at infection, usually either the collapsing type or no other specified. These two type of FSGS you see in the picture when somebody has infection related changes causing FSGS. Now, why do a genetic testing? It is very variable, as we all know, and it is still evolving field. But think about steroid as a medication which has long-term side effect. And if you want to put somebody on steroid, right patient and the right setting, and it's better to do it, if you can, just to diagnose, and if it's genetic, you may not use steroid. Again, if you don't have genetic testing available, you can use steroid, but just to bring that in your, everybody realize that it costs a lot, long-term complication. And if you look at the slide, age of onset is also important. And, the variable age of onset, early age or later age, you think about genetics, maybe playing a factor. And again, it's variable. So that's where, nothing is simple in medicine, I guess. But that's why we talk about genetics. When do you think about genetics testing in FSGS? As I was saying, young age of onset of FSGS, okay? All of a sudden, or gradually getting progressive. And FSGS with syndromic presentation, as I was saying, that syndromic, it is kind of happening gradually, coming and going. Doesn't really fit in the general picture. And family history, I would say family history is obviously very important. If somebody has family disease, look at the family tree. In US, we sometimes do linkage analysis, but that is more difficult, cumbersome. We do other Sanger sequencing. Those are more advanced. And that has been really approved for disease like ADPKD, but it's also coming up in FSGS too. We'll talk about that. Family history is always important to consider doing genetic testing. Again, adult onset FSGS with a family history of FSGS is something to think about genetic. Primary FSGS that are resistant to your immunosuppressive treatment. You think about, is anything else going on? Secondary FSGS without any obvious cause being identified. So you look at the biopsy looks like secondary FSGS. There is partial foot pulse effacement. So is something else going on that it's secondary but not respond, no obvious cause. Then adult onset FSGS with clinical and pathological features that do not support a primary or secondary form. It's kind of outlier that this patient has FSGS picture, nephrotic range proteinuria, but other clinical syndrome like cholesterol or metabolic syndrome or pathological findings are not supporting either the primary or secondary form. But obviously it has the diagnosis of FSGS from biopsy, but cannot be placed in any of those classification like cellular or tip variant. So you think about that, it might come to your mind. Again, indication, we can also think about this way, that there is a kind of a discordance between clinical and pathological finding. and nephrotic syndrome with FPE, segmental FPE. So FSGS diagnosis, but there is no other secondary causes like no absence of virus or drug. And the other side of the story, there is diffuse FPE, food pulse effacement, that's suggestive of primary FSGS, but there is no nephrotic syndrome clinically. So those patients, you have to think about genetic testing if possible. That slide I was showing earlier, this is a bigger picture. They've done some study, and if you look at steroid resistance nephrotic syndrome, FSGS, adult onset sporadic, 6.6% has that mutation, monogenic inheritance, Mendelian inheritance monogenic, and 5% has mutation in GBM protein, which are polygenic inheritance. GBM proteins are sometimes difficult to pinpoint because they're polygenic and they're mutation. And 10.4%, so highest number is apolipoprotein 1 variant. And this is one of my focus of a talk and also the general. Apolipoprotein 1 is one of the genetic factors that really play a role in different kind of diseases, obviously kidney disease too, including in transplant also. And by expanding gene panel, we can provide almost 22% patient that in that study they will be able to diagnose the genetic variation of the FSGS. Again, this kind of a certain group of population in USA, it may not be applied, can be applicable to other scenario like Bangladesh or Asia or Europe. But just to keep in mind that if proper genetic study, we can diagnose maybe up to 1/4 of genetic disorders of FSGS. What gene testing for? So evolving with the increased numbers of gene are coming in, playing a role, almost 60 now, and they're different penetration. That's another thing. It can be recessive, dominant, or it can be X-linked, and there can there's also can be de novo mutation. I mean, you have a patient who has primary FSGS and get a kidney transplant, then you may have other mutation that might be causing genetic FSGS down the road. And it can be causing renal limited FSGS, that mutation, or it can be caused the whole syndromic FSGS that can happen, like a different kind of rare diseases like nail patellar syndrome. FSGS mutation, so directly involve the podocyte structure. If you can remember the first, I think third or fourth slide I showed you, the podocyte structure, the nephrin, S1, S2, the informin 2, TRP6. The other ones are glomerular basement membrane. So if you look at those proteins, the COLA protein, 4A3, 404, 4A4, 5, there's a kind of overlap with the diseases of like thin membrane disease or Alport syndrome. So there is always connection. Sometimes Alport syndrome, a patient can eventually develop FSGS because of those genetic mutation. Something to keep in mind. Again, just to bigger that thing that here's in the apolipoprotein variant is very important because they're more susceptible to podocyte injury. That's how the inflammation starts, the podocytopathy. The G1 and G2 variants are important. They protect you from in African population from trypanosoma, but at the same time, African population has higher chance of FSGS, and especially this gene also have connection associated with the collapsing type of GN. No HIV on those patients. Again, pathological features in those patient population, you cannot really correlate the FSGS with the light microscope finding, the one I showed you, cellular or collapsing or NOS. It can also vary. The genetic variation, it can be mild, moderate, severe FPE. Often nephrotic syndrome is more seen when there's a diffuse food process effacement. So whenever there's a diffuse effacement, you expect to see nephrotic syndrome picture. And again, most of the genetic variants are resistant to immunosuppression, but few of them, like TRP6, those can respond to partial response to steroid or CNI. Maybe it is effect on the podocyte. Mutation again, we talked about that. Now, clinical evaluation of a kidney biopsy, we look at that. It's kind of a breakdown: nephrotic syndrome, non-nephrotic syndrome, and nephrotic syndrome with segmental foot process effacement. So that is the one we'll do for genetic testing for sure. Non-nephrotic syndrome, segmental food post effacement. We know the secondary cause, no role for genetic testing. And nephrotic syndrome with diffuse FP, first-line therapy is obviously there's a primary type. You respond to therapy, and if it's resistance, you look at genetic testing. So treatment is okay to start steroid if you think it's primary or idiopathic, but if it's resistant, we do genetic testing. And if patient has non-nephrotic syndrome with diffuse effacement, you go for genetic testing. I'm going to skip those just to show you one, the Wilms tumor, childhood, adolescence, and they can have the FSGS syndrome, and also the nail petalus in the first one. It can be that the syndrome of FSGS can show clinically. Again, genetic testing of adult onset FSGS, they're done in a Mayo Clinic, Rochester, and they have seen those are the common one like a nephrin and invertin foramina and the cola. So these are the common ones, few of them that in future, hopefully in Bangladesh, we can get those too. So what is the future for genetic testing? Novel gene, we can look at that, environmental influences, and also the sequencing, as we're saying, Sanger sequencing is a tool for clinical practice. And let's see if there's any role of genetic factors in secondary FSGS, like apolipoprotein 1 variant. Will they make patient with secondary FSGS worse prognosis? I was talking about the African American population and African population, COVID-19. We have seen a good number of collapse in FSGS, and that also have associated with the apolipoprotein 1 variant. And again, these patients doesn't have any HIV or any other viral inflammation, but they have the COVID and they have developed FSGS. Again, another study on FSGS that was published on the CJSON, and apolipoprotein 1 variant associated with the developing on FSGS. As I was telling you, early diagnosis, developing FSGS, and faster progression of kidney failure in affected patients. And there's 17-fold higher odds of FSGS in general if they have apolipoprotein 1 variant. If you have HIV, that almost doubles, almost 30 times higher. ESRD patient also in FSGS, immunosuppression, and that also can lead to FSGS picture. If their baseline creatinine is less than 30, the higher chance of ESRD, hypertension baseline. These are risk factor that which patient you have to be more aggressive treatment to prevent ESRD. So in men, it's more common to develop FSGS ending to ESRD than women. Something to keep in mind. Now we're looking at the treatment guideline. As we all know about that, we look at again different times. All of them, all across the board, we see that RAS blockade is always important. Renin-angiotensin system is very important. And then we look at the glucocorticoid and medication in case of primary FSGS with nephrotic proteinuria. And there's always kind of a time-limited kind of approach in glucocorticoid in children 4 to 6 months, adult up to 4 months. So I will treat 4 months at least for FSGS with adult with glucocorticoid. This is resistant to FSGS, you go for CNI. And then if glucocorticoid intolerance, if they have uncontrolled diabetes or they have hypertension uncontrolled, you can go to a CNI as a first-line agent. People with osteoporosis, they cannot tolerate sometimes glucocorticoid. So that's okay to use the CNI as a first-line agent in kind of primary FSGS with nephrotic syndrome. Adaptive FSGS, as a general, there is no role for immunosuppression, RAS blockade, and control your blood pressure. And as a general, also make sure the cholesterol gets better. Secondary FSGS, virus-induced treatment of underlying causes. As I said, treat the virus, treat the HIV, take out the drugs. Again, another slide just to give an idea of FSGS, how to approach. Steroid dose, 1 milligram per kilogram, again 4 to 8 weeks, up to 16 weeks in adult, and then we taper it over next 3 months. So 6 months, 7 months, we use the steroid. Remission, sustained remission, we stop corticosteroid, we monitor the monthly urine test for proteinuria. That is the worst prognostic indicator with the proteinuria. Even GFR is stable. If the steroid is resistant or toxicity, we will go to the CNI inhibitors and start low, and we up titrate the dose depending on response. And in the remission case, if there is a relapse happen again, they're steroid dependent. We can always repeat that, but here the guideline says you can consider adding CNI not to stop it, you add the CNI and taper the corticosteroid to minimum dose. I'll show you a slide that combination of CNI and corticosteroid has better outcome long-term than either of them alone in case of steroid dependent or relapse cases. In case of secondary FSGS, if patient is not responding to RAS blockade, you always think about the overlap category, maybe some genetic variation. And if the patient has persistent nephrotic syndrome, you can consider steroid on those secondary FSGS. And if they don't respond, you can even go for CNI. If they're not responsive, then obviously we not treat, we not use too many toxic medication. We might keep it for in future for after they get a transplant. And again, if they're persistent nephrotic syndrome despite RAS blockade, I might even go for a genetic testing if available before I commit them to steroid or CNI. And then if you use the CNI inhibitor, if the response group is CNI respond, you need to continue that for at least 1 year because they have a high chance of relapse. And then 1 to 2 years, and the taper to minimum dose to minimize toxicity for long term. So these are treatment we have to monitor and long-term treatment. Again, if there is no remission after 6 of steroid, you can always start CNI for minimum 6 months. You continue for, these are the secondary type we're talking about. ACE inhibitors, lipid lowering agents, and other supportive care. Partial remission or complete remission means less than a gram of proteinuria or partial remission. Then you continue CNI for again 1 year. Low dose corticosteroid plus minus is your choice. But again, if it's my patient, if it's responsive, I might just keep the steroid low dose and then wind down on the CNI after 1 year. And you need to continue the RAS blockade. On the patient not responsive, you can consider other medication like mycophenolate. You can do rituximab, but you continue your supportive care aggressively for secondary type. Again, treatment of secondary FSGS involving the underlying condition, and it all focus on reducing the intraglomerular pressure, reducing the protein leaking. So that's why the RAS, the renin-angiotensin medications blockers are the first line treatment. Overlap, we talked about that. In certain patients, overlap syndrome, we can use the steroid in both primary and secondary obese patient adults, obese, and children with FSGS and known mutation. We can use that if we use the maximum dose of RAS blockade and they still have proteinuria, nephrotic range. Because no matter what, the nephrotic range proteinuria, we have to bring it down because that is the highest risk of having ESRD. So that's why we can even use CNI or steroid for those patients. Other scenario, rapidly onset full-blown nephrotic syndrome, despite we know that may be because of hypertension, obesity, you can still use a CNI inhibitor or steroid on these two situations. You can consider as a first-line agent. Genetic treatment, we talked about that earlier. We know the target. We can give the corticosteroid, like we know there is a TRP6 or there is a nephrin mutation or any of those podocyte-related genetic mutation. 4 weeks, corticosteroid is okay. If no response, then you do CNI for 2 months. Look at the time duration on this test, this genetic type. You don't use it for a long period. So 2 months, up to 2 months of CNI, but you still continue the other medical management, ACE inhibitors, lipid lowering, supportive care. And if they don't respond after total like maybe 3 months or 4 months, you have to stop them. Don't use that. And if the target is unknown, if the target is identified, that the coenzyme Q or COQ6, these are rare variety. If you can find them, there is no role of steroid on those population or immunosuppressive medication. You can do medical management as well as supportive care. There's some study that you can do some supplemental treatment like coenzyme Q or vitamin B12. Again, verdict is still out there. But bottom line, if you see those druggable target that was not like nephrin or TRP6, or you don't know, but you have the other mutation, those type, then you don't use steroid those cases. Then we go like this is the one that I was talking earlier about, that glucocorticoid alone, the solid line. And if you add the CNI with glucocorticoid, and you see the chance of having a survival and ESRD-free survival, there's significant difference that was seen in this graph at the end of like almost towards the 4 years down the road. There's a difference between the chance of having ESRD. Under research, new medication we talked about in future, we already using this ACTH, the adrenocorticotropic hormone. There is a natural form and there is a purified form called Actha gel. It has been approved now. Then we all know about the SGLT2 inhibitors, like all the flozins, the canaflozin, dapagliflozin. Is kind of becoming more of supportive treatment along with RAS blockade. And the next one is also MR2 antagonist. These are the ones that act with the mineralocorticoid receptor antagonist at the glomerular in the arteriolar level. And one of the one that is approved is called Carandia, which is also a good medication add-on therapy, especially people with hypertension and diabetes. You can add those to the secondary FSGS. Oral budesonide, that has been approved for already. FDA has approved it for IgA nephropathy. Tarpeo, sorry, I don't want to see the trade name. Budesonide, and then this last one is also the novel mechanism. You look at that both the endothelin receptor in the blood vessel, and also you look at that angiotensin receptor. If you look at the glomerular. The vasa recta on that area. So this medication has been shown promising, but they're still under trial. They look at dual mechanism to improve that, that glomerular filtration, improve that leaking of the protein. It's called sparsentan, and as I was saying, the ACTH gel, adrenocorticoid hormone gel. We look at a study in CJSON. And that was several years ago, and see that the chance of recurrence of proteinuria, it goes down as we proceed, like 2-3 years down the road. They maintain relatively subnephrotic range for sure proteinuria, and these patients sometimes we can even use genetic type of FSGS because they are less toxic than steroid long-term side effects. Now this I'm going to go quickly just to talk about how the AI is coming into play soon. You look at the study called Neptune. They look at different parameters, the protein creatine ratio, and they look at the kidney biopsy, and they look at like about 100, about 224 patients, and they look at all the data, and they look at if they have the machine learning. They did the whole programming. And they kind of try to predict the list of which patient will get worse. If you look at that patient who have basically FSGS, the higher chance of worsening kidney function, lower chance of respond to compared to minimal change disease. If the patient has other findings like they have a lot of scarring on the top of that, tubular atrophy, they have higher chance of not responding to treatment. If they have, on the other hand, if there's no changes in the interstitium, there's higher chance of complete response, focal, diffuse. There's also some benefit, some effect on response, and so they kind of look at that. And if you have, proteinuria, there's also some effect on that. So something interesting to look at that, how the machine is giving you this information. Same thing if you look at that, tubular atrophy is a big risk factor. The disease can progress, and if you have no changes or minimal change, the lower chance of disease progression, and also in respect to treatment response, if the patient has more than 45, older patient may have a better response if you treat them early on. Diffuse maybe have a better response of treatment response chance. And then if you have other findings like age, all genetic factors play a role. If you have an IFTA, a lower chance of response to treatment. Now, if you talk about prognosis, it all depends on the treatment, how the patient responds. Everybody is different, as we know. Physician medicine, Islam was talking about that. But you don't want to keep them untreated. You have to treat them as much possible because this is a high chance of progressing to ESRD. And the nephrotic syndrome response to treatment is 10%, less than 10%. We acknowledge that fact, but who knows, one person may respond to better than another person. And patient who has non-nephrotic proteinuria and normal kidney function, obviously we know that that will be better response to treatment. FSGS can happen after kidney transplant, and that's what we look at, that super protein, the soluble protein urokinase receptor, protein kinase receptor, and certain patient we can do even plasmapheresis to see if there's any. But these are more case by case. Take home points, as I was mentioning earlier, FSGS is not a specific disease. The primary FSGS usually have diffuse food poisoning and full-blown nephrotic syndrome. Genetic FSGS, always think about the patient. Does it fit the regular general picture, or something hoto alada onorokom? They will think about that. Younger patient, family history, immune resistant patient, and other pathological feature, clinical feature. Think about that. Mutation, common ones, যেগুলি আমরা mention করেছিলাম, যে podocyte gene like nephrin, podocin, TRP6, and then apolipoprotein 1. I think if this is something that will be coming in horizon soon, the apolipoprotein 1 variant, and GBM gene are more variable, and sometimes they're difficult to diagnose because the 60 more, and the number is still going up overall. In general, FSGS does not, the genetic form doesn't respond to immunosuppression, but the good thing is that they don't really recur after transplant. So there's always, at the end of the tunnel, there's a light. So if you transplant those patients, this will not really recur, those genetic variation. There's some mechanism that was happening in the native kidney that was driving that inflammation, that the donor kidney doesn't cause, the genetics doesn't happen there. In conclusion, precision medicine, we talked about that. We have always think about secondary cause FSGS to exclude, especially if you try to start on steroid. Patient entering remission, even partial remission, have favorable outcome. Anything persistent nephrotic proteinuria has worse outcome. ESID in 10 years. We talked about therapy with RAS blockade, good blood pressure control. I will also add good cholesterol control. And we talked about the steroid, in adults 16 weeks, and complete remission achieved, whichever. If you have a remission earlier, we can use less steroid. And then we taper off slowly. That's the important thing. We taper off gradually over a period of 6 months. And if patient cannot use steroid, yes, we can go to calcium inhibitors or MMF. That may be my first agent rather than going for Cytoxan because of toxicity. But you can use that if you need to. In steroid responsive patient relapse, we can use those medication. That's what I'm talking about. If they relapse, then you can consider cyclophosphamide or CNI or MMF. And also think about that patient who are relapsing on steroid. Maybe they don't have FSGS. Maybe it has, who knows, maybe they have minimal change disease. Maybe you're looking at scarring that time. I'm just saying that you always think about others side. Steroid-resistant FSGS, we can always use cyclosporine. We just give you the dose. But again, the duration is 6 months. In remission, you can go down slowly over 1 or 2 years. With the aggressive approach is important. At least in 50% patient, it can attain some remission, and we can prevent dialysis in 5 years, and in those patients if we do aggressive treatment. Here's a reference slide. There's some study from New England Journal of Medicine. There is a couple of other references I can share with you if you want. Up to it is a good source too. And then any question?
Nazmul, we'll take the questions later on.
Okay.
But because we have the case presentation and then we can do it. So, truly comprehensive and extensive work done. I thank you for your time. And you started from basics towards going towards precision medicine, which is absolutely fantastic. And for the audience, we will have this on Facebook Live. So I know there's a lot of contents that you probably like 1 or 2 slides more than others. So you will have access to that. So আমি মুহিবুর রহমান ভাই, আপনি যদি অনুমতি দেন, Brigadier General Bhai, he is traveling. Can I let him do some comments and question and then?
Yeah, definitely.
Okay.
Definitely.
So, Brigadier General Bhai, আপনি কি আছেন? Yes. আসসালামু আলাইকুম ভাই again. So আমাদের দেশে যে বায়োপসি গুলো হয়, তো যেমন আমাদের ছোট ভাই প্রফেসর মবাশের উনি এখানে আছেন. He has about 500 biopsies, but many of the diagnosis comes as focal global glomerulosclerosis. এটা হলো, আপনি যদি একটু কমেন্ট করেন এটার উপরে. সেকেন্ড একটা কোয়েশ্চেন হচ্ছে যে আমরা খুব এক্সাইটেড যে বাংলাদেশে ইলেকট্রন মাইক্রোস্কোপ আসছে এবং আপনার ইনস্টিটিউট ইজ হ্যাভিং ট্রেনিং অন দ্যাট. তো এটা আমাদের এই এফএসডিএস এবং অন্যান্য ডায়াগনোসিসকে কিভাবে হেল্প করবে, এই দুটো কোয়েশ্চেন যদি আপনি একটু আমাদেরকে বলেন.
Assalamu alaikum. Thank you very much. In fact, Dr. Nazmul has covered widely everything, almost everything, including pathology, pathogenesis, and everything. In fact, regarding your question, this FSGS, this diagnosis itself is absolutely a morphological diagnosis, and this focal terms, it can cover only a single glomerulus. It can involve only a single glomerulus. So it's quite challenging for any pathologist to identify if the involvement is very less, very small number. So it's very difficult to identify that specific glomerulus to pick that one. If the glomerular number is quite high, in that case, we easily can pick that FSGS easily. For this FSGS diagnosis, we usually use HNE staining and silver staining. The silver staining, in fact, this silver staining is not available everywhere in Bangladesh. For that reason, sometimes this silver staining is quite a very good stain to identify a very deep lesion like FSGS. That can be identified very easily by silver staining. But that staining is not available everywhere in Bangladesh. For the region, sometimes we even miss in HNE staining, the routine staining of the histopathology. And what was your second question?
Second question was, we are excited to know that the Armed Forces Institute of Pathology is going to get an electron microscope. So my question is, how is going to help us with FSGS and other diagnoses?
Yeah, definitely. In fact, the electron microscope requirement is essential for every case, and especially for FSGS. If we can identify the sclerotic lesion in light staining, that is light microscopy, it is enough to diagnose this FSGS. But in the confusing cases, especially sometimes we use some term unsampled FSGS. That is the FSGS is not sampled by during this biopsy. So in those cases, this electron microscopy will be in great help. But there is some problem. This FSGS, there will be food process effacement, as well as in case of minimal change disease, there will be also this effacement. So this we have to put in all clinical scenario, as well as light microscopic finding, and with that, this electron microscopy can be help. Only by electron microscopy you cannot differentiate this minimal change disease and FSGS. So we have to keep in mind. There will be effacement. Yes, there will be some level of effacement in minimal change disease. It will be lesser effacement, but in case of FSGS, there will be diffuse effacement. And in another thing, in secondary FSGS or where this basement membrane is affected in FSGS, in those cases there will be very less amount of this effacement. So in those cases, this electron microscopy will not be in that helpful. So even that, definitely the accuracy will be increased with the introduction of this electroscopic finding. And
thank you so much
regarding this,
wonderful comments and wisdom. So we are very excited that we have AIMS trained pathologists in Bangladesh, and hopefully we can pick your brains a lot in future. So now I'm going to Professor Muhibur Rahman. Before we go into cases, can you put some comments and some words of wisdom? Professor Muhibur Rahman.
Okay. Thank you. Dr. Imtiaz, thank you very much for inviting me. And it was a very excellent talk. We learned a lot about FSGS and also especially the genetic variants and genetic types. And in fact, FSGS, as Dr. Jainal already said, it's not a disease. It's just an histological appearance of the glomerulus. So it's a combination of many diseases. I think a lot of people think that minimal change disease and FSGS are two diseases of the same spectrum because because many patients who are diagnosed to have minimal change disease at the young age was later identified as FSGS, or it could be the problem with the biopsy specimen as well. So as we have got electron microscopy now, so it definitely enhance our diagnostic ability, and so we'll be able to better diagnose our patients. So I think Dr. Nazmul has covered everything, especially the genetic type, and in fact, according to the recent guideline, KDIGO guideline, they've divided FSGS into 4 types: primary, genetic, secondary, and FSGS of undetermined cause. So, and primary one usually presents with sudden onset or full-blown nephrotic syndrome, most of the cases. And in secondary cases, you usually get non-nephrotic proteinuria, and there is an identifiable cause in the secondary FSGS. And genetic, there are lots of genetic mutations which can result in FSGS. So these are the 4 types. And when patient has got features of secondary FSGS, but there is no identifiable cause, those are called FSGS of undetermined cause. So these are 4 types, and he has clearly explained. Primary FSGS usually occurs in younger patients. Secondary FSGS usually happens in older patients, and proteinuria is usually nephrotic range in primary FSGS and usually subnephrotic in secondary FSGS. And other, usually in primary FSGS, serum creatinine level is usually normal at the diagnosis, but in secondary FSGS, it quite often we get elevated elevated serum creatinine level. And in primary FSGS, there is diffuse extensive food process effacement, and in secondary FSGS, it is segmental food process effacement. And primary FSGS can be of any variety, but commonly it is FSGS of FSGS NOS, but in secondary FSGS mostly perihilar. So, and if we find a case of FSGS and we is full-blown FSGS with nephrotic syndrome, it has got a proteinuria more than 3.5 and has got a serum albumin level less than 30 gram per liter. So whether patient has got full-blown picture or not, so it is likely to be primary FSGS, and then we should treat it with immunosuppressions. If there is no response, I think we should go for genetic testing. Genetic testing, the patient doesn't respond to steroids. But in case of absence of nephrotic syndrome, like in people who has got proteinuria less than 3.5 gram, with or without hypoalbuminemia, or patient has got only nephrotic range proteinuria, but serum albumin is normal. In those cases, we should try to find out a secondary cause and secondary form of FSGS, and we should also consider genetic testing, genetic screening in those cases, because as we have just learned that in different genetic forms, there are specific treatment for those genetic variants of FSGS. So this is a very, because we get a lot of, in our country, in Bangladesh, we get a lot of patients, a lot of patients FSGS due to obesity. So, and in many cases, we can't steroid doesn't work. So those are steroid-resistant FSGS. I think in those cases, if we could do genetic testing, we could do much better. We could treat them with the newer options of therapy, and probably we could cure them. We could, or at least we could increase their dialysis-free survival. So these are the few things I wanted to say. And it was an excellent talk, and I learned a lot of things from Dr. Nazmul. Thank you, Dr. Nazmul, for your effort.
Thank you, sir.
Thank you so much, Professor Muibraman, for your wonderful comments. Like Professor Mubashir and Professor Nurluda, please hang on, because we will let you comment after your respective students have presented their case. I'd like to quickly recognize the Professor Shamim Ahmed. He's also in our audience, and we're glad to have you, sir. So I'd first ask Tahmidur Rahman, MRCP, Phase B MD students from Chittagong McGill College. So Tahmidur Rahman, please go ahead and quickly present your case.
Assalamu alaikum. I am Dr. Tahmid. I am a PhD student at Chittagong Medical College. I'd like to present a PowerPoint presentation. So it will be great if you can make me co-host, and so that I can share it.
Nafisa, Nazmul, please take your slides.
Stop share.
Yeah, just stop sharing. And Nafisa, please let Dr. Tahmidur Rahman share his slides. Yeah, can you upload your slide, please, Dr. Tahmidur Rahman? Yes,
Yeah.
Go ahead.
Yes,
Thank
sir.
you.
Our patient, Mrs. Mukta, 22 years of old, hypertensive non-diabetic student, presented with the history of generalized swelling this time in our hospital with low urine output for last 3 months. She had a history of episodic facial swelling since 5 years of age, but she didn't took any medical advice for that until 13 years of age. Then she visited a doctor who diagnosed her as nephrotic syndrome on clinical presentation, big drop proteinuria, low albumin, and hypercholesterolemia. Her urinary protein was 7.3 grams per day, and her serum complement levels were normal. This is the story of 2014, when the patient was 13 years of age, and secondary causes of glomerulonephritis are then excluded on the absence of relevant clinical features, negatory laboratory investigation like negative ANA, anti-DSDNA, CANC and PANCA, and hepatitis B and C antibodies, and there were no similar family history. So initially, she didn't go for renal biopsy and treated with prednisolone 1 milligram per kg body weight, but there was no response. And she then underwent renal biopsy after 6 months of treatment with steroid. And the renal biopsy showed a typical case of focal segmental glomerulosclerosis, where there is increased mesangial cell, increased matrix, and out of 18, 5 glomerulus showing segmental sclerosis. There is no crescent or no deposit on immunofluorescence. Between year 2014 and 16, she was prescribed prednisolone along with cyclosporine for 6 months, and her proteinuria came down to 3.5 gram at 3rd month of treatment with cyclosporine. After that, she discontinued the treatment herself, and within 3 months, her proteinuria increased to 12 gram per day. She was prescribed cyclosporine 4 milligram per kg per day again, along with low-dose steroid for the next 12 months. During this period, she developed a painful knee swelling, which was later diagnosed as joint TB and treated for 18 months with antitubercular medication. And she also developed hypertension, which was managed with amlodipine and losartan. After 11 months of treatment with cyclosporine, the patient was in partial remission, but she developed renal impairment, which was thought to be due to cyclosporine toxicity, and it was initially tapered and then discontinued, and her creatinine becomes normal. The other causes of AKI was evaluated and excluded. Between year 2018 and 19, she was prescribed with tablet cyclophosphamide 2.5 milligram per kg per day for 8 weeks, as she relapsed again after discontinuation of cyclosporine. But there was no improvement of proteinuria. So she was then given IV cyclophosphamide 1 gram monthly for 6 cycles along with low dose prednisolone, which was associated with complete remission of the disease for 3 months. But after completion of 6 cycles of cyclophosphamide and after 3 months, she relapsed again. This time she was prescribed with tablet mycophenolate mofetil 2 gram per day. This treatment was continued for 1 year, and she was in partial remission within this period with normal renal function. She was treated with conventional antiproteinuria drugs and other supportive treatments over the course of her whole illness. But she did lose to follow up during the whole COVID period between 2020 and up to middle of 2023, and she didn't took any medication for almost 2.5 years. She presented 2 hours in nephrology department this time with creatinine of 3.3 and UTP of 19.8 gram. Her previous ultrasonogram showed that her kidney size were around 12 centimeter, but this time it is 9.5 centimeters with echogenic kidney and poorly maintained CMP. Her corrected calcium was 9.5. She was on calcium because she was on and off steroids. Phosphate level was 5.1 and PTH level was 180 milligram per day. So as the creatinine is actually higher, but UTP was 19.8 gram, a repeat renal biopsy was done. This time it shows that she is actually ongoing and she still has this first segmental glomerulosclerosis, but it is progressing to CKD. This time the glomerular number was 5. There was mild increase in mesangial cell and matrix matrix. Glomerular basement members was normal. Among 5 glomerulars, 2 glomerulars showing global sclerosis, 1 showing segmental sclerosis, and 1 showing periglomerular fibrosis. The tubules, which were normal in previous biopsy, now shows atrophy and interstitial fibrosis and are covering almost 20% of cortical renal parenchyma. There is still no deposits, but blood vessel shows mild medial thickening and foci of high granulosis in the wall. And the report was it is progressing to CKD. So now the patient is actually in our hospital, and our plan is to give her another course with MMF because as her GFR comes down to 19 right now, we cannot give her cyanide, and with steroid. The patient and her family was counseled about the disease prognosis and future treatment plans, but it is difficult for them to continue the treatment as her farmer father has already sold all his farming lands during the course of her treatment and in debt. She got married in 2021 without consulting to her doctors. Her marriage ended when her husband learned about her disease. This time, most of the investigation and treatments are provided by the Department of Nephrology, CMCH, and very unlikely she is going to take the mycophenolate in future, but we have counseled her and to take the medication. So this is my patient Mukta. So I'm thanking you all of us to give me this great opportunity. It is a privilege to present in Planetary, and I also want to thank my mentor, Professor Dr. Mohammad Nurul Huda sir, for giving me this opportunity. I would like to conclude my presentation by saying just one thing: what can we do right now in a patient in a resource-limited country and a very poor patient, and the patient already is going to CKD stage 4. So thank you all to give me this opportunity.
Thank you so much, Dr. Tamidaran. Really appreciate your time in taking care of this patient. And this is really a practical, very practical situation in Bangladesh. You know, people have limitations on others, and my hats off to people that are navigating through these limitations every single day. Now, obviously, this is unfortunate. Let me ask the professor now. Professor Nurul Huda, do you think this patient is likely to have a genetic cause?
First of all, I thank Nazmul for excellent and brilliant presentation. An elaborate presentation. I learned a lot from his presentation today, and maybe this patient has genetic correlation or genetic variation, but we cannot prove it because we have no genetic testing yet in Bangladesh. Hope that in our country now electron microscope is there. By this we cannot comment about the genetic variation because there is no selective things by electron microscopy or light microscopy. You can tell that this has genetic link, but only age is the favorable points in for this particular patient. This patient may have genetic variation, and another thing is she is relapsing on and off, and definitely it is not collapsing variant, because I think to my experience, Moguram sir is there, Shangim sir is there. They have much more experience than me. In Bangladesh, collapsing variant I think is rare, and rather primary variant is more common, and response to steroid and other things is much better in our country. This I think thanks God, in our country collapsing variant is very rare, and genetic variant I don't know because I cannot comment because we don't have any genetic testing yet.
Thank you, but the way that the patient responded to steroid, and then obviously she could not be compliant, maybe because of her look versus because they didn't have money. She also responded to CNI. She also responded to cyclophosphamide. So it looks like this is not a genetic variant. It's just an unfortunate case where she could not cope up with the therapy and she could not afford that. You guys helped her as much as possible. A question, actually Dr. Tanvir Latif asked a question. What was the purpose of doing the second biopsy? Were you looking for something different? Because at that time the creatinine was already 3.
Yeah, because there is a reversible factor is there. There is 19-gram proteinuria. When your glomeruli is sclerosed, most of the kidney damaged, you don't have 19-gram proteinuria. In that case, proteinuria should be reduced. So as this patient has 19-gram proteinuria and serum albumin is low, we think that is there any other things? Our first biopsy was correct or not? Or is there any other things with this renal biopsy we want to sure? And is there any possibility of giving second time treatment like mycophenolate mofetil, which is only we cannot. This patient has only 2 options: the steroid plus mycophenolate mofetil or rituximab. But rituximab is too costly, so we cannot prescribe this patient. Only one hope is mycophenolate mofetil. And you may ask why you will prescribe think about mycophenolate mofetil, because there is a reversible factor, 19-gram proteinuria. It will lead the kidney to more rapid progression to the CKD. If we hold the proteinuria to partial remission stage even, in that case we can hold the progression, at least we cannot hold but limit the progression to CKD. Only no drug prevent fibrosis except only one drug proven, finerenone, which is proven prevent fibrosis in diabetic kidney disease, not in any GNA yet. And sparsentan is also a good drug. It is also under trial, but though FDA approved in IgA nephropathy probably, but it is not approved for FSGS yet, as far as I know. But we are hoping that this drug would also in future maybe recommend for FSGS, and it will give some hope to us. And I think by reducing proteinuria, we can reduce the progression of this patient, and particularly this patient always respond to drugs previously. Whenever you give the drugs, cyclosporine, mycophenolate mofetil, cyclosporine. Every time this patient responded to drug, but she became worse because she stopped all medicine for the last 2.5 years in COVID period. That's why she deteriorated. But when she was on treatment, she was not like at present situation actually. Thank you.
Thank you, Dr. Nuluda. Like Brigadier General said, the quality of the biopsy is very important. We want to see 20 glomeruli. She had only 2. So suppose out of 20 glomeruli, 16 were sclerosed. This patient will not be eligible for any therapy, not immunosuppression or anything, because then it is chronicity basically. Then you just try to use the ACRV, spironolactone if you can. Now, DAPA-CKD in trial, there were 100 patients with FSGS. Their proteinuria was reduced slightly. There was a little slower slope of GFR going down, but it was not statistically significant. And for Sparsentin, good comment on DUET trial and DUPLEX trial, there was very significant benefit in reduction of proteinuria in both these trials compared with, I think, Evapro, irbesartan. And I would ask Nazmul.
I think another subgroup post hoc analysis or subgroup analysis done in AMPA kidney, and they also found there's no significant difference in FSGS patient.
Right. So if this young woman was in America, obviously assume that the creatinine is up and we had good quality biopsy showing that extensive scarring, we would actually prepare her for renal transplantation. That would be the next step. Rather going into any further immunosuppression, we'll continue the supportive therapy. Nazmul, there's a question for you. Actually, a question for me, but I don't know the answer, so I'll ask the professor now. So it's like, would you please comment on FSGS with a proliferative variety that is apparently common in Bangladesh? FSGS with the Columbia classification showing proliferation.
Okay. So, I was talking about, proliferative GN picture, FSGS can overlap. So kidney biopsies obviously will guide your treatment. And then, so if you think that the biopsy shows that they're partial effacement and you're thinking it is most likely a secondary consequence of previous proliferative GN or other primary glomerulonephritis, first and foremost, I'll optimize medical management. There is there's type 1 evidence that you use RAS blockade and you maximize the dose. Even if your creatine takes a hit, even if your GFR goes down a little bit, the long-term prognosis is better if they can tolerate and the proteinuria goes down, number one. Number two is that I'll point out a couple of clinical pearl. Sometimes I've seen patients, even in America, vitamin D deficiency. And if you give vitamin D high dose, there's good study, any kind of disease spectrum that does help with proteinuria. So it's an easy hanging, easy fruit, okay? And then third of all, as we're talking about neuromedication, I think Dr. Nubu said, any medication like timely intervention is always important. If you want to give something like, if you can get those medication, something like sparsentan or even dapagliflozin, if the GFR tolerate. Now, if you come to nephrotic range proteinuria on this patient, and there is, if you have a complete food process effacement, you can think maybe there's a new disease happening. Maybe it is a component of primary FSGS. And in primary FSGS, you treat with RAS blockade, and then if you need to give steroid, you give steroid, and you look at the outcome and proteinuria. I will be hesitant to put this patient on immunosuppressive medication if the GFR, as Intesba was saying, if the GFR is too low, because they might eventually need, because there's two hit now. One is proliferative GN before, now the patient is developing nephrotic range proteinuria. But if you use steroid, if you use the immunosuppressive medication, I'll talk to the patient in an open discussion and get the patient discuss about that and use something least toxic, depending on the patient is woman or a man, if she's childbearing, if she planned for pregnancy in future, depending on those. By my two go therapies, CNI inhibitors, if I want to add that. I do love rituximab a lot, because it's like for anything, after steroid, rituximab is used most medication except SLE. So I will use rituximab if insurance or the financially, and then we'll monitor this patient. I mean, we'll monitor closely.
Thank you. I cheated a little bit while I was waiting because I didn't know the answer. So obviously the Columbia classification, we know that TEEP variant is the best variant and the collapsing variant is the worst. Now, it is very uncommon to have a proliferative variant, but their prognosis is poor. So sorry, Dr. Arshad, I don't know anything beyond this, so I can't. So we'd like to
may I have a
just
question?
add a few,
Okay. Sure,
few
sir.
words. The thing is, I don't know why previously we used to get the diagnosis of focal segmental proliferative glomerulonephritis in many of our biopsy specimens. When we used to send our samples to lab aid. So, and that was a common diagnosis. And we did find any such variety in the textbooks, focal segmental proliferative glomerulonephritis. So then at some point we realized that these are FSGS proliferative variety. So because they look like a proliferative glomerulonephritis, so, and it doesn't involve all the glomeruli, involves some of the glomeruli, and there is segmental involvement. So the diagnosis used to come as focal segmental proliferative glomerulonephritis. So I believe that focal segmental FSGS or proliferative variety is common in our country.
So it could be that actually underlying pathology of proliferative GN, but then when there was significant damage to the kidney, then it started having the adaptive changes and developed the FSGS feature. I mean, theoretically, it's possible, I guess.
Yes, possible, but I don't know exactly but this patient used to respond to steroid. That's why I was thinking it could be a variety of FSGS.
Right. Well, I was looking at Biomed Research International. They said that according to their database, is pretty rare. So now I'll let the next presenter. This is Dr. Asma. She's also Phase B resident doing her MD in nephrology. Thank you so much, Dr. Asma. Please present your case.
Walaikum, sir.
Please upload your slides.
Sir, make me the co-host so that I can upload.
Nafisa, please, Dr. Tami, please take out your presentation and let Asma share. Yeah, can you upload now?
Sir, I could not upload.
Nafisa, please let the doctor upload, Dr. Asma, Asma. Yeah, good. Please go ahead.
Respected learned audience and my respected teachers, I am Dr. Asma, Phase B resident of nephrology, is going to present the second case. A 14-year-old boy with generalized swelling. Rafi Islam, 14-year-old student, normotensive, non-diabetic, hailing from Nakhalpara, Dhaka.
Asma, we are not seeing your slides.
have to click on your PowerPoint tomorrow. PowerPoint click করলে আসবে।
PowerPoint.
সবচেয়ে উপরে টপে।
স্যার এখন কি দেখা যাচ্ছে স্যার?
না, পাওয়ারপয়েন্টে ক্লিক করো তাহলে আসবে।
স্যার পাওয়ারপয়েন্টে তো
না, যে তোমার ইয়াটাতে ক্লিক করো, যেটা তোমার এই যে যেটাতে তুমি FSGS গ্রাফি যেটা লেখা আছে।
স্যার এখন দেখা যাচ্ছে স্যার?
না, আরেকবার ক্লিক করেন।
আচ্ছা।
ডাবল ক্লিক, এটা খুলছে না তো, ডাবল ক্লিক।
স্যার আমার এখানে দেখা যাচ্ছে খুলেছে স্যার এখন স্যার
ওপেন।
তাহলে এখন শেয়ারে যাও, স্লাইড শেয়ারে যেতে হবে।
স্যার এখন দেখা যাচ্ছে?
না, উপরে বাম দিকে ওই তোমার পাওয়ার পয়েন্টে উপরে বাম দিকে যে ট্যাব গুলো আছে ওখানে একটা শেয়ারেরও জায়গা আছে, আই থিঙ্ক থার্ড ফ্রম দ্য লেফট। ওখান থেকে তুমি শেয়ার করতে পারো, কিন্তু তোমার আগে তোমাকে শেয়ারে যেতে হবে।
স্যার আমি তো মানে ওখান থেকে দিচ্ছি, হচ্ছে না কেন স্যার?
শেয়ার
Okay, go ahead. Please read. We can understand. Okay.
তুমি পড়ে ফেলো, অসুবিধা নেই, আমার মনে হয় তুমি পড়ে ফেলো। হ্যাঁ,
ওকে স্যার।
Go ahead.
স্যার
হ্যাঁ, আমরা শুনতে পাচ্ছি।
জি স্যার, স্যার
হ্যাঁ।
করছি স্যার। Rafi Islam, 14 years old, student, normotensive, non-diabetic, hailing from Nakhalpara, Dhaka, presented with the complaints of generalized swelling for 4 months. And initially he noticed puffiness on his face, and subsequently swelling involved legs and then became generalized. Swelling is not associated with shortness of breath, yellow coloration of eyes or urine, constipation, cold intolerance, or cough or chest pain. He also noticed reduced urine output for 3 months, which was approximately 2 glasses in 24 hours, normal in color but frothy in appearance. He gives no history of fever, burning, micturition, lowing pain, or any history of skin rash, sore throat, joint pain, oral ulceration. He has no previous history of similar type of illness. None of his family members has suffered from such type of illness. On general physical examination, patient looks puffy, bilateral petal pitting edema present, temperature is normal, blood pressure 110/70 millimeter of mercury, and pulse is 84 beats per minute. Bedside urine reveals protein 3+ and RBC nil. Alimentary system examination reveals as abdomen is distended and ascites is present, evidenced by positive shifting tunnel. Respiratory system reveals no evidence of pleural effusion. Other systemic examination reveals no abnormality. With these complaints, he consulted with the physician and took tablet furosemide for 1 month. His swelling decreased a bit. He came to NICU in OPD and advised for renal biopsy. He didn't admit at the time and consulted with another physician where he was put on tablet prednisolone 50 milligram daily from 8 February 2023. His swelling subsided after 1 month but reappeared when prednisolone was tapering at 10 milligram per week at dose of 20 milligram per day. He was then admitted in NICU and renal biopsy was done at 3rd May 2023. Now the investigations show albumin 3+, RBC 2 to 4, PASL 2 to 4. Complete blood count is normal. UTP, this is the 24-hour UTP report. First UTP is done on 6th February 2023. It was 3.7 gram per day. Then he was put on tablet prednisolone 50 milligram daily. After 1 month, that is 4th March 2023, it was 0.7 gram per 24 hours. Then the steroid was tapering, and on 4th April, the urinary total protein was 1.32 gram per 24 hour, and he again swelling developed. And at the time of renal biopsy in our hospital, UTP was 3.1 gram per day, and serum albumin was also low, 1.6 gram per DL initially, and on 4th April. And serum creatinine, renal function was normal all along the period. And serum C3, C4, ANA, anti-dsDNA, Priyanka, and was negative. RBS was 4.8 milligram per DL, and serum cholesterol was 473 milligram per DL. HbSAg and anti-HCV was negative. Ultrasonogram of the KOB reveals normal size kidney, and chest X-ray was normal. Then we performed renal biopsy. Renal biopsy shows multiple sections stained with hematoxylin and eosin, periodic acids, mesotrichome, silver methenamine, and congorate, renal cortical parenchyma area containing up to 31 glomeruli, none globally sclerosed. The remaining glomeruli reveal mild increase in mesangial matrix and cellularity, and 10 glomeruli reveal segmental tuft sclerosis with intraglomerular hyalinosis and focal prominence of visceral epithelial cells over the sclerosed segments. Peripheral glomerular capillaries in viable glomeruli do not show significant thickening. Significant proliferative and or exudative activity is not observed. There is no evidence of tuft necrosis, subendothelial or congophilic deposits, intracapillary nodules, or intracapillary thrombi in the visualized glomeruli. Tubular atrophy and interstitial fibrosis involves less than 10% of sampled cortex. Viable tubules show focally prominent cytoplasmic vacuolar change. Scattered inspissated hyaline clusters seen in tubular lumen. Focal chronic interstitial inflammation is noted. Many interstitial foam cell aggregates are noted. Arterioles appear unremarkable, where arterioles show focal hyalinosis and vacuolization in smooth muscle cells. DIF shows IgG and IgM in segmental entrapment. IgA, C3, C1q, kappa light chains and lambda light chains were negative. Impression was features of mildly enlarged glomeruli with segmental tuft sclerosis in 10 glomeruli over 31 glomeruli. DIF studies do not show significant glomerular immune deposits. Focal chronic interstitial inflammation and many interstitial foam cells are seen. Present biopsy shows segmental sclerosis lesion and many interstitial foam cells, a correlation with clinical features and relevant investigations parameters, including lipid profile, serum albumin levels, and may be performed in view of subnephrotic range proteinuria and many interstitial foam cells. An ultrastructural examination of renal biopsy is also recommended to evaluate the status of visceral epithelial cell food process and ascertain the primary versus secondary nature of segmental sclerosing lesion and glomeruli, and to evaluate any structural GBM abnormalities. So our final diagnosis was focal segmental glomerulosclerosis. After admission in NICU, the dose of tablet prednisolone increased to 60 milligram daily from 4th April 2023. He is fully compliant to medications. Despite taking tablet prednisolone for 11 weeks, his swelling persists. Then tablet tacrolimus is started at a dose of 0.05 milligram per kg per day from 22nd May 2023, when UTP was 3.5 gram per day and steroid is tapering. Tacrolimus trough level on 9th June was 3.1 nanogram per ml, and dose of tacrolimus was increased. Despite all, his swelling reappeared and UTP was increasing with decreased serum albumin. Now, ongoing management is general management like high protein diet, salt restriction, tablet prednisolone 10 milligram, tablet tacrolimus 6 gram in 2 divided doses, tablet diltiazem 60 milligram, furosemide, tablet spironolactone, atorvastatin, calcium, vitamin D, pantoprazole, and injection human albumin. After 1 month, the treatment outcome was urine RE shows albumin 3 plus RBC mean, and UTP was 5.5 gram per day. Serum albumin is 2.3 gram per DL. Serum creatinine is 0.8 milligram per DL. Serum electrolyte is normal, and tacrolimus trough level done on 20 July is 4.3 nanogram per ml. So what will be the next plan of management? Thank you. Thanks. Sorry for the inconvenience, and thank you, our Professor Shanur Alam sir, for giving me the opportunity to present this case.
Thank you, Dr. Asma. No problem. We could all understand your voice pretty clearly, even though the slides didn't work. We have a general understanding. There's an unfortunate, again, young person who actually has been steroid resistant. So, Professor Shanur, so do you think a genetic testing would be appropriate, and how is it going to change our management?
Thank you, MTS Bhai. Thanks to Dr. Najmul for his elaborative presentation, and Planetary Health Academia for inviting me and giving me the opportunity to participate in this webinar. I think the case presented by Dr. Asma, it's a primary type of FSGS, and the treatment given, I think, in our country, the two things are important, and it is important for our management. That is, one thing is the compliance of the patient on the part of or on the patient part, and the other is the cost. Many times, the glomerular patients of glomerular diseases, they present like a book picture. That this case is presented with proteinuria and generalized edema and proteinuria, and typically nephrotic range. I think nephrotic range proteinuria. When we ask the patient to do a biopsy for histological diagnosis, they don't agree, and ultimately they go to another physicians, and they are put on steroids in inadequate doses, sometimes in inadequate duration, and then ultimately they come back, and then again we do renal biopsy, and the diagnosis is made. So, and another thing is that when we put the patients in a specific medicine, they don't continue for our prescribed duration. Many times they discontinue by themselves, and ultimately the outcome is not, I think, outcome becomes worse. So in this specific case, the patient was given first steroid. It was responsive. His proteinuria came down, but again reappeared. Proteinuria reappeared after doing renal biopsy. We started with steroid, and again but that time I think the adequate duration was not maintained. For to declare it as steroid resistant, we should continue steroid for at least 16 weeks. That is 4 months. So in that case, I think it is not properly maintained, and he was put on tacrolimus, and you see the tacrolimus trough level was not maintained, because the tacrolimus trough level should be 5 to 6, between 5 to 6, but it was 4. So these are the problems, and this is a practical problem for us to treat such cases. Thank you.
I think excellent comments, Dr. Sharnoor, and again, hats off to all our practicing colleagues who are practicing Bangladesh with this very, very significant amount of limitations. I think even then you're trying to do your best, as you can see. So I guess, yes, if the FK trough level should be at least 5 and above, some people say 5 to 10. And then I think somebody also had a question about the permeability factor issue. So there was an article published in KI in 2022 from Bristol, England, and they said they cultured podocyte with FSGS patient serum. So then to identify there is the presence of permeability factor. And if this is a monoclonal protein, it could actually respond to plasma exchange. Professor Radhakrishnan, he presented a case, or he mentioned about a case that this young person, nothing really worked, then transplanted, and 10 years since transplant, the patient is getting plasma exchange sometimes once a week, sometimes 3-4 times a week, but still have been off of dialysis. So that is fascinating. I thought it was very interesting. But like Dr. Nazmul says, that the Neptune group, the Nephrotic Syndrome Study Network, they are trying to match a genetic profile with clinical picture as well as significant amount of biochemicals, including vascular endothelial growth factor in the urine. There's TNF in the urine, and alpha-1 macroglobulin in the endothelium. All these things they're trying to match to see whether the patients could be cohorted. They made 3 cohorts. X cohort was worse than Y and Z cohort. So then, as AI is going to direct us, okay, this patient falls in X cohort. So you tell the patient about prognosis, because in 10 years, they're likely to go into ESRD and dialysis. So you prepare them and aggressively do the non-immunologic things. And if you do immunology, at least patient has the right to know, and then maybe enroll in the studies. Now, APOL1, which is, thank God, we don't have that problem in Bangladesh, but in African Americans in America, they have it. But there's a drug called VX147, which actually has been shown to be effective in blocking the gain function of APOL1. And I think they're trying another one on TRPC5, it's called GFB887, which is helpful. I'd like to invite, again, Dr. Nazmul to present your questions so that Nafisa is going to keep a tab who can answer the fastest and win our present, that is the Bluetooth headphone.
Okay, I think everybody can see my screen now, inshallah.
Not yet.
Not yet, okay. I have to share it. I think they can let me share the screen again.
Nafisa, please allow Dr. Nazmul to share his screen.
Okay, I think I can go now. Hold on, let me see. Can you see that now?
Yeah, Dr. Nazmul started sharing, right? Go ahead.
Okay, so I'm going to go to my quiz. And I can tell you, if you guys were not sleeping, you can get the answer for my presentation.
Inshallah.
Let's see who was awake. No, I'm joking. That's okay. Let's go that. Okay. I think I'm going to go to the slideshow from the big. Yeah, I think you're in the slideshow. Okay. Okay. So quiz number 1. That's the main quiz. We have an extra quiz. We have a tiebreaker. So, which histopathological feature has the highest prognostic value in any type of FSGS? Everything is the reason why I do that. I pick up this question because, as I said, biopsy is important, very important for FSGS. So, which features? Food process effacement, number 1, extent of glomerulosclerosis, segmental versus global, interstitial fibrosis, presence of crescent, or glomerular scarring. There's one. Choose one.
Interstitial fibrosis.
Yes.
Just type it in, and Nafisa, note that.
Everybody else says that. I mean, he just told the answer.
Sir, would you please repeat the correct answer again?
Yeah, that's the correct answer.
That is the correct answer. Yes.
So shall I go to the next one, Jazbai, or
yes, next one. Yeah, please.
Okay, next one. I think okay, answer. Okay, next one, the bonus question 2.
Sir.
Yeah.
একটু আমাদেরকে অ্যান্সারটা স্যার চ্যাট বক্সে দিতে হবে, যেহেতু চ্যাট বক্সে অনেকেই আসলে অ্যান্সার করে ফেলেছেন আসমা আপু আর কি বলার আগে। তো সেই ক্ষেত্রে স্যার আমাদের আসলে কেউ যদি আনমিউট করে বলে সেটা আমাদের কারণ করাটা ঝামেলা।
Nusrat, Nafisa in charge. So I'm sorry, we have to answer in the chat box and not say that. So whoever was able to answer in the chat box first is the winner. So Nusrat is gonna decide about that. Okay. So again, please answer in the chat box. Don't say verbally. Okay. Next question. Bonus.
Quiz 2. Which of the following is an autosomal recessive gene causing FSGS? TRP6, inverting foramen 4, apolipoprotein 1, nephrin, or super? Choose one.
The coding, you know, right?
The tiebreaker, right? Because it's genetics, we talk about genetics.
I know. I think we'll give them another 30 seconds to answer. Actually, yeah, we're done. So, Nusrat, you have the winner. Oh, okay. Sorry. What is the right answer?
Right answer is the autosomal recessive is nephrin.
Nephrin. NPHS1,
Yes.
isn't it? Yeah. So NPHS1. So yes, it controls the filtration slit for diaphragm.
Diaphragm, yes.
So Nafisa, the answer was number 4. Nephrin.
Sir, sorry, but no one answered number 4.
So then we should go by the whichever was the first one. So then and some people were correct on first one. So who was the first in first one? Quiz 1 will be the winner. So do you have a winner now?
Sir, I have a confusion about the right answer of quiz number 1. Would you please repeat one more?
Quiz number 1, right
No,
answer is interstitial fibrosis. Number 3.
Three.
Number
3. Interstitial fibrosis. Yeah, number 3.
Sir, we got our winner, Dr. Tahmid.
Oh, congratulations. Then, okay, very good. So,
Thank you.
Dr. Tahmid, please post your address so that Nusrat Nafisa will arrange to send you your present.
Address and contact number. Thank you.
Okay, address and number. Thank you so much, Nafisa. So, Dr. Mahfouz, are you there? Okay, no. Then I guess, Nazmul, you have the last word.
I think it was very learning for me. আমার ভালো লাগছে ওর সাথে কথা বলে। I think one thing I will point out that as we have electron microscopy now, we should use that resources as much possible because it really helps to guide treatment. Obviously we do primary diagnosis with light, but I think in Bangladesh we're hopeful that the electron microscopy is available. And the second thing I will point out is that as I was saying that genetic testing, not only for the patient, it helps with the physicians too. Because when I commit somebody with steroid and high dose immunosuppressive medication, I just worry about long-term side effects. These are young people, like in their 14, 15, 20 years old. They have a long way to go. And then especially patient, you're worried about compliance. On those situation, you might not give those medication, that's kind of a thing that I kind of talk to the patient that be serious. You have to take the initiative on this medication. You have to be part of the team. If you don't think that you can follow on this medication, take it regular basis, don't take those immunosuppressive medication, rather steroid and medical management. That's all. Thank you. So সবার খুব ভালো লাগলো কথা বলে সবার সাথে।
Professor Muhibur Rahman, bhai, please have the
ইমতিয়াজ ভাই, আমার একটা কোশ্চেন ছিল ডক্টর ইসের কাছে, নাজমুলের কাছে, যে I think you come across a lot of obese patients with proteinuria. Do you go for renal biopsy for those cases, all the cases?
Depend করে what the extent of proteinuria, because I kind of suspect these are secondary. And secondary FSGS, we don't have to do biopsy if you can minimize the proteinuria by medical management. But এখন যদি আপনি ধরেন you treat with RAS blockade, maybe add some Farxiga or dapagliflozin or empagliflozin, তারপর proteinuria যদি improve না হয়, before doing steroid, yes, I will go for a kidney biopsy.
I think, can I add a few words? I think if an obese patient comes with proteinuria, if the proteinuria is not nephrotic range, I think you should put the patient on ACE inhibitors or ARB first, maximum dose, and other supportive measures, control blood pressure, and ask the patient to reduce weight, and also some dietary restrictions. So, and you control his blood pressure, and if the patient, you can also add SGLT2 inhibitors. So after that, if the proteinuria does not decrease and remains elevated, in those cases, I think you can go for a biopsy.
Yes, and losing weight is always important. Losing weight is very important, as you mentioned.
Losing weight is important.
আমার একটু প্রশ্ন আছে নাজমুলের প্রতি, সেটা হচ্ছে আমরা যে কেসটা নিয়ে আলাপ করলাম তাকে কি এখন আমরা চিকিৎসা দিব কিনা? তাহমিদ যে কেসটা নিয়ে আলাপ করলো,
চিটাগাং থেকে যেটা বলেছিল, চিটাগাং কলেজ থেকে যারা ক্রিয়েটিন হলো 3.3 একটু স্কার, কিন্তু গুড
আমরা কি তাকে ইমিউনোসাপ্রেসিভ দিব কি দিব না?
I
আমার
think
মনে হয় নুরুল ভাই,
আমি বলি যে
হ্যাঁ
আপনি
বলেন।
বায়োপসিতে আপনি 5টা গ্লোমেরুলাস ছিল, তার মধ্যে 2টা হচ্ছে গ্লোবাল স্ক্লেরোস, একটা হচ্ছে পার্শিয়াল স্ক্লেরোস, দুইটা পার্শিয়াল স্ক্লেরোস। তো এই কেসে আর ইমিউনোসাপ্রেসিভ দেওয়ার আমার মনে হয় খুব একটা রোল আছে বলে মনে হয় না। হ্যাঁ, কারণ এই পেশেন্ট এখন ইমিউনোসাপ্রেসিভ দিয়ে ইউ ক্যানট ডু এনিথিং with that patient. So you should prepare the patient, you should give supportive treatment and prepare the patient for dialysis or transplantation.
I agree.
I think you're right. You did the right treatment. You did all the way, but the complexity issue, it's just unfortunate that, or IFTA, the fibrosis was not last time. Koto chilo IFTA where fibrosis was 20% or 10%?
20%.
20%.
কিন্তু ওর
কিন্তু এটা
proteinuria
স্যাম্পলিং
কিন্তু
এর
এখনো
হতে পারে।
ওর proteinuria কিন্তু এখনো 19 গ্রাম।
I mean, still, I don't think immunosuppressive is going to work.
Yeah, it's difficult. Usually this kind of patient I've seen, like, we kind of minimize immunosuppressive medication. Unfortunately, if it was in America, I would have gone maybe try some like CD20 inhibitors or rituximab, which is less nephrotoxic, but chance of improvement is much less. And going back to that question, sampling is obviously up. Patchta glomeruli enough now, but you have treated on that and people responded initially, but the compliance and I think it is difficult. Genetic testing, it can give you some more information on that, but if you look at the EM also help you. But yeah, I'll talk with the patient and tell them that basically, he's young, maybe go for kidney transplant, maybe try like preemptive kidney transplant if creatinine get worse before dialysis.
Now, I think
আমাদের
we need
আরেকটা প্রশ্ন ছিল, সেটা হচ্ছে আমাদের কিছু কিছু রোগী আমরা ইউনিলেটারাল স্মল কিডনি, তার হয়তো ওই কিডনিটা ফাংশন করছে না, অপোজিট কিডনিতে হাইপারফিল্ট্রেশনের জন্য প্রোটিনুরিয়া অনেক বেশি, লাইক 4 গ্রাম প্রোটিনুরিয়া। তো এটা কি এটা কি FSGS? আমরা তো বায়োপসি করতে পারতেছি না, তার তো সিঙ্গেল কিডনি, আর একটা
actually we do biopsy single kidneys.
আপনি সিঙ্গেল কিডনিতে বায়োপসি করতে পারেন if you do it cautiously, and সুতরাং এটা বায়োপসি কন্ট্রাইন্ডিকেটেড না, কিন্তু এটা একটা কিডনি ছোট আর একটা কিডনি থেকে প্রোটিন হচ্ছে ইজ লাইকলি যে অ্যাডাপটিভ টাইপ অফ সেকেন্ডারি FSGS হতে পারে, যেহেতু কিন্তু আপনি বলেন 4 গ্রাম ইজ কোয়াইট হাই। হ্যাঁ, আপনার তাও ইজ পসিবল স্টিল, or it could be something else, some other GN.
Minimal হলো, membranous হলো, I don't want to miss those. আগে যখন আজকে থেকে 20 years আগে তখন আমরা ফেলো ছিলাম, তখন সিঙ্গেল কিডনি হলে we'd be cautious about those. But এখন I think the techniques has improved because আমরা সব CT guided করি, and the complication rate is extremely low. পেশেন্টের থেকে informed consent নিয়ে আমরা করি। আমার যে পেশেন্টের দু একটা ব্লিডিং আছে, কিন্তু they usually tamponade inside the kidney. They usually never will lose a kidney, or theoretically I guess they can die. আর আমরা যখন ফেলো ছিলাম তখন একটা এরকম 600+ পাউন্ডের মানুষ আসলো, তার কিডনি বায়োপসি করতে হয়েছিল। তো আমাদের টেবিলের ওজন হলো একটা লিমিটেশন আছে, টেবিল গুলো সাধারণত সিটি স্ক্যান টেবিল 500 উপরে যায় না। তো তারটা 600 হওয়ার পরে স্পেশাল টেবিল এনে তাকে করা হলো। তখন আমরা ট্রান্সজাগুলার রাউটে গিয়ে টিপসের মেশিন দিয়ে ভেইন দিয়ে গিয়ে তারপরে আমরা বায়োপসি করার চেষ্টা করলাম, দুই একটা কর্টেক্স পাওয়া গেছিল। We could not quite get a good answer from that. So তারপর থেকে কিন্তু এখন we can have bigger needles. As long as the CAT scan machine can handle that, we can do biopsy in obese people. Actually, we do pretty good. আর হলো যেটা একটা younger person who does not generate much blood pressure, say their systolic blood pressure is 120s, এখন আমার একটা ACRB, তারপরে হলো মনে করো অ্যান্টাই ফাইনারিনন অথবা স্পারনোল্যাকটন, তারপরে কি আমি SGLT2 দেওয়ার কি আর ওর ব্লাড প্রেশার থাকে? কারণ by the time they are all antihypertensive, the blood pressure starts going down. Now, একটা thing about rituximab, I think I was listening to this study. They said they have T cell activity কম যারা থাকে, they respond very well to rituximab.
Yes.
And experimentally, they have seen that the T cell activation কম থাকে, then anti-CD20 works really well. তো যেহেতু আমাদের এখানে একটু অপরচুনিটি বেশি ওষুধপত্র দেওয়ার, তাহলে ওগুলা I think these are all going to be incorporated in the Neptune study group, so that we'll have a general idea যে কোন দিকে আমরা যাব, because this thing is so complex. I think hitting, throwing a stone in the dark is not going to be very helpful.
Good question. Thank you.
শাহানুর আর কিছু বলবে?
ঠিক আছে।
শামীম স্যার কিছু বলবেন স্যার?
That's very good. That's why that
আচ্ছা, ঠিক আছে। Well, thank you so much, everyone, and thank you. Special thanks to Dr. Nazmul for your wonderful assimilation of all that data, and I think this is quite a bit of resource for all of us, like a reference resource for us. And thanks so much for our expert panelists for your wonderful discussion on cases. Thanks to Planetary Health Academia and our sponsors, United and Incepta. Thanks to Nusrat and Nafisa for organizing the meeting. And thanks everyone who have been staying up all night to support us. If we have missed any questions, please do submit that on my email, then I'll be happy to answer those. Thank you. Good night.
Thank you. Assalamu alaikum.
Assalamu alaikum.
Assalamu alaikum.
Assalamu alaikum.